Welcome to this special edition of Diabetes Core Update, where we will discuss oral health and diabetes. I'm your host, Dr. Neil Skolnik, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This is one of those topics where I say to myself, how could I have missed the importance of this topic for so long? And I suspect the same is true. Actually, I know the same is true for many of my colleagues. So we're going to have a lot of learning during these two podcasts that are devoted to oral health, an absolutely critical topic for everyone, and particularly for people with diabetes. These two special editions of Diabetes Core Update, focused on oral health, are sponsored by Haleon, the makers of Periodontics. Let me share a word before we start from Haleon. Patients with type 2 diabetes are more likely to have gum disease, cavities, and other oral health problems. Periodontics is a daily use toothpaste that is clinically proven with twice daily brushing to reverse and prevent gingivitis, an early form of gum disease. Visit HaleonHealthPartner.com to learn more about the Periodontics portfolio of oral health products and how they can support your patients' gum health. Now back to our podcast. I feel so lucky to be able to talk about this topic. This is an incredibly important topic to discuss. And joining me today to discuss this is Dr. Wenche Borgnakke. Dr. Borgnakke, DDS, MPH, PhD, is an adjunct clinical assistant professor of dentistry in the Department of Periodontics and Oral Medicine at the University of Michigan School of Dentistry. She approaches our topic today from the perspective of both dentistry and public health, and has published well over 100 articles in the dental literature. And one of her areas of interest is the relationship between oral health, diabetes, and blood sugar control. Welcome, Wenche.
Hello, Neil. I cannot tell you how excited I am to be with you and that you are interested in the links between oral health and general health, and specifically in the case of diabetes mellitus. The mouth is indeed an integral part of the body, so without oral health, there can be no true overall health. Nonetheless, a patient's oral health status is largely completely ignored by all diabetes care professionals, as the topic still is not part of their curricula, despite an abundance of sound scientific evidence in the literature. For example, a crude search on the keywords oral health or periodont, asterisk, and diabetes resulted in 23,556 records identified today. I'm thrilled to convey the good news that attaining and maintaining a healthy oral cavity can be a clinically significant tool in diabetes prevention and management.
It is pretty amazing. You and I had talked about this before this podcast. Your excitement about this topic comes through readily. And I have to agree with you. We just have not, in the traditional medical curriculum, covered this topic the way that we should and to the degree that it deserves. So we are going to cover this topic over not just one, but two podcasts. Now, in the first podcast, today we're going to go over the background of why oral health and dental issues are important to people with diabetes. In the second oral health podcast, we're going to go over some practical recommendations for clinicians about how to approach oral health. And I really encourage our clinician listeners to come back, not just for this, but for that second podcast. This is an incredibly important topic. We're going to cover a lot of ground. To start out, Wenche, can you discuss the effects of diabetes on oral health and whether people with diabetes are generally addressing this issue the way that you feel they should?
In short, hypoglycemia adversely affects all the tissues in the oral cavity, including the two very common diseases all over the world, namely caries, also known as cavities, and periodontal diseases, with the diseases around dental implants being of increasing importance with their rapidly increasing application. Additionally, diabetes can cause dry mouth and contribute to taste disturbances, temporomandibular disorders, burning mouth syndrome, oral mucosal lesions, and even oral cancer. Sadly, since oral health and maintaining oral health is not part of the diabetes management in general, most diabetes patients, it is safe to say, unaware of the importance of the oral cavity.
It's an area that has been so long neglected that I want to make sure all of our listeners understand the different terms that we're going to use. So can you give us a quick overview of periodontal disease? What are the main types of periodontal disease, and how does periodontal disease develop?
Mm-hmm. First of all, the adult dentition consists of 28 permanent teeth, plus between 0 and 4 third molars, also known as wisdom teeth. The by far most common periodontal diseases are caused by dental plaque, which is a whitish, almost tooth-colored soft mass that sticks to the teeth at the gingival margin or gum line, then consists of food remnants and microbes, mostly bacteria, but also viruses and fungi. If that plaque is not removed properly, the biofilm will develop and bacteria will irritate the gingival tissues that become inflamed and swollen, which predisposes the less anaerobic bacteria to flourish. If not removed by proper home oral hygiene measures every day, the inflammation continues and causes irreversible breakdown of both the soft and hard tissues surrounding the tooth. These tissues include the soft gingiva, which is known as the gum, which is the part you can see around the teeth, and then dental alveolar fibers, and that are connective tissue fibers that attach the tooth to the surrounding alveolar bone, and then the bone itself. If untreated, the breakdown will lead to loosening and eventually complete loss of the tooth. Notably, this progression is not gradual, but occurs in spurts, influenced by the environment, various stressors, acute infections, and other challenges to the immune defense. The same scenario will occur about dental implants, except there are no fibers to hold implants in place, and therefore the progress is much, much faster and is extremely challenging to treat peri-implantitis, as it is called, once it is started. Another kind of periodontitis means around the teeth. Another kind develops around the tip of the root, where necrotic pulp tissue escapes. Pulp tissue is the inner soft part of the tooth that consists of connective tissue, nerve endings, and arteries, and they can die after a trauma or an infection or a very deep cavity. So this necrotic tissue exudes through the tip of the tooth into the bone, and that's then called periapical periodontitis, with apex meaning the end or the point. Another totally different type of periodontitis is not due to this dental plaque, but due to hypoglycemia, which is so important for the development of periodontitis that diabetes is incorporated in the most recent periodontist case definitions by an international workshop in 2017 that follows the medical stage and grade paradigm. In hypoglycemia, there's a dose-response relationship between the level of hypoglycemia and periodontitis severity and extent. Likewise, in the situations with implants. That is, the more severe the level of hypoglycemia, the more severe the periodontitis or peri-implantitis is. In other words, only if diabetes is well controlled is the risk of periodontitis or peri-implantitis and eventual loss of the tooth or the implant similar to that in normal glycemia. To give you a frame of reference for how common periodontitis is, the prevalence of periodontitis in dentate U.S. adults ages between 30 and 80 years is 42%. So that's more than 4 out of 10 people actually have periodontitis. But when you look at people who have diabetes, for those same adults, the prevalence is 60%. So that means it's 50% or 1.5 times greater than in people with normal blood glucose levels. When we look at the oldest, 65 and older, then about 3/4 have periodontitis, and about 83% of seniors with diabetes have periodontitis. In other words, persons with diabetes have a much greater risk of periodontitis than those with normal blood glucose levels. It also works in the opposite directions, in which individuals with periodontitis are at much greater risk for having diabetes than those without periodontitis.
It's interesting, Wenche. We'll talk more about that bidirectional relationship in a little while, but the level of effect of diabetes on oral health is nothing less than astonishing. That 50% increase in the risk of periodontitis is a lot. Now, we have that increase in the risk of periodontal disease. What are the consequences of that risk?
The consequences of periodontitis are first and foremost loss of the tooth. While this loosening is happening, the patient may actually experience no symptoms whatsoever, which is the dangerous part of it. And that's why we call periodontitis the silent disease, because there may not be any symptoms until the tooth is loose, at which time it is very difficult to salvage the tooth. And periodontitis can only be diagnosed clinically or radiographically. In other words, the patient, him or herself, cannot necessarily know they have periodontitis. But some symptoms can occur. For instance, bleeding when you're brushing your teeth. That should not occur. There can also be spontaneous bleeding, which is, as the expression is, bleeding without any incitement. And people with diabetes are much more likely to have bleeding. You can think of it this way, that in people with hypoglycemia, there will be much more bleeding in the response to the same quantity and composition of the dental plaque compared to normal glycemic individuals. You can also experience a bad taste, dysgeusia. You can have halitosis, bad breath. You will see retraction of the gum line due to the breakdown of the soft tissue so that the teeth look longer, long in the tooth, as the expression is. The teeth, while they are loosening, but before falling out, of course, they can be tilting, twisting, or turning, and basically wobbly when you try to use them for eating or biting off. So when the teeth are loose, they are painful to use for any practical purposes. So the tooth will eventually fall out. And you can say, so what? We have 28 of them. What does that matter? But it matters incredibly much to the vast majority of people. For instance, there are some examples from the literature that have been investigated clinically. And you have a feeling of being handicapped. You're not a whole person anymore if you are missing teeth. You have a decreased feeling of self-worth created by increased self-awareness and shame. You weren't able to take care of your teeth. You don't have those pearly whites that are so attractive in our society. So you have embarrassment. You can be reluctant to have a meal together with other people or to smile in public. You can have less frequent and less high quality of socializing because you're just so ashamed. you practically have a decreased ability to bite off and to masticate, to chew your hard food items, which will invariably lead to intake of a soft diet of often poor nutritious quality that's usually laden with sugar, salt, and fat, and in turn leading to poor nutrition. In other words, the patient with loose teeth or missing teeth is not able to follow your guidance in terms of what a healthy diet should be taken in by your patients with hypoglycemia, and the rest of us for that matter. Important things like your appearance during job interviews are also mentioned as very large contributors to people's decreased quality of life. Because all of these factors contribute to an overall decreased quality of life. There's a very large body of scientific evidence for the impact of oral health on quality of life, with an index called Oral Health Impact Profile being the most used globally. And I'll mention the 7 dimensions this index looks at just to illustrate the wide range of kinds of effects that oral health and missing teeth among them have. The index looks at functional limitation, physical pain, psychological discomfort, physical disability, psychological disability, social disability, and handicap. And these questions were originally 49 in number, and they have been tested all over the world. And we can get back to shortened versions that could actually be used in the clinic to ask people if they think they might have periodontitis. People with diabetes consistently score worse than their normal glycemic counterparts because they are much more prone to periodontitis and tooth loss as well as periimplantitis due to their impaired immune responses.
Thank you. You've made a critically important case for us paying attention to oral health. Now, as if that weren't enough, and it is enough, but can you go over with us that bidirectional relationship that also happens? Not only does oral health affect everything related directly to oral health, but it also affects a lot of systemic illnesses. It has systemic consequences. Can you discuss some of the research there?
Yes, and that actually is fairly new that we have had sufficient scientific evidence to make systematic reviews. The first one was in 2013, so not very long ago. So there are principally 3 different but related mechanisms that underlie the systemic effects of periodontitis or any oral infection. First of all, bacteremia. The bacteria in the deep pockets between the teeth and the gums, especially those anaerobic ones, they can very easily penetrate into the bloodstream. There's only 10 to 16 layers of cells between the open pocket, and the bloodstream. And not only can they travel around, they do travel around the entire body. And we can get back to how they do that. But that's the first mechanism. The second one, and the very important one, is inflammation. The bacteria in the pockets cause both local and systemic inflammation. The polysaccharides, a unique class of cysteine proteinases termed gingipains from the outer shell of a bacterium called Porphyromonas gingivalis, or PG, they are especially and exceptionally pro-inflammatory and elicit very strong inflammatory responses. The third mechanism is immunologic. Some of the oral microbes are strong antigens that lead to the formation of antibodies, and these antibodies notably survive even after the infected teeth are extracted. So since the inflammation of the gingiva only is reversible, even by home oral hygiene alone, I will focus on periodontitis, which is the irreversible loss of both the soft and hard tissues around the teeth, as I mentioned. And you can imagine when the space between the tooth and the gingiva deepens, first due to the breakdown of the gingiva, then also the alveolar bone and the fibers that I mentioned are holding the tooth into the bone. more of those anaerobic bacteria in the plaque that thrive and multiply disproportionately. So they lead to dysbiosis in the oral microbiome. And some of these bacteria turn pathogenic, although they are part of the commensal oral microbiome in health and in homeostasis, in balance. So this Porphyromonas gingivalis has a companion called Fusobacterium nucleatus, FN, and they are prime examples of such commensal oral micro members that are turning pathogenic. These bacteria, once they get into the bloodstream, they get around, they start in their planktonic form, which is just freely floating, and that's the most dangerous position because they can be gobbled up by the macrophages. Then they can hitch themselves onto a cholesterol raft and get around the body. And especially Porphyromonas gingivalis has developed this technique where it lets itself be gobbled up by a macrophage, but it does not dissolve inside. On the contrary, it uses the macrophage to get around in the body, and it multiplies during that travel. And then when it finds a cool place to chill, it jumps out and invades the tissue. And that cool place to chill could very easily be an atherosclerotic plaque in which the bacterium multiplies and could be the last straw that breaks the camel's back and causes a thrombus to dislodge, and then in turn cause a ischemic stroke or myocardial infarction, depending on where it ends up. Cardiovascular diseases and events.
So it sounds, Wenche, that both through an inflammatory cascade, similar to what we've talked about on other podcasts, obesity causes inflammation. That general increase in inflammation, along with the mechanism that I think for most of us is novel, direct infection, there's this increase in cardiovascular outcomes, both coronary disease and cerebral vascular disease. Is that a correct interpretation of that?
You absolutely got it, Neil. Absolutely. Akin to obesity, periodontitis elicits a chronic, low-grade level of inflammation. Right?
That is something. And then, so you had mentioned that there also are other effects.
I would like to mention arthritis, rheumatoid arthritis and psoriatic arthritis. And you would often see patients have their condition flares up in periods of progression. Sorry. And this keystone bacterium or community activator, as the Porphyromonas gingivalis is called, it has developed a special ability to citrullinate proteins, which is a hallmark of rheumatoid arthritis. So there's evidence that the rheumatoid arthritis cases have improved substantially upon cleaning up the mouth by removing infected teeth and treating the rest of the teeth and gingival tissues. Periodontitis is driven by the same risk drivers as all other inflammatory diseases. And those chronic inflammation-based diseases are the main causes of mortality these days, where we don't die as much as we used to from infection. But therefore, it's not a surprise that the same people often suffer from multiple chronic inflammation-based diseases. And it was actually a Finnish cardiologist headed up by Mattila in 1989 that first published a study where, because these cardiologists, they noticed that their patients they were doing surgery on had very poor teeth. It was also a physician team headed up by Dr. Lin, who in 1975, they found the basement membrane to be thickened in the gingival biopsies of diabetes patients and actually suggested that gingival biopsies could be used as adjunct to diagnose diabetes. But that has not caught on as far as I know. And so this is just microcirculation in diabetes patients is impeded in the gingival tissues. On the other hand, it was a dentist by the name Russell Ross who in 1995 first described and illustrated the cell biology of atherosclerosis. So professional collaboration has always been needed. We needed each other, but it's not always executed.
Wenche, it's fascinating. Clearly, there's a relationship, this bidirectional relationship we talked about between, for instance, diabetes, elevated blood sugars, and poor oral health. And then in the other direction, poor oral health leading to all the things you mentioned, cerebral vascular disease, cardiovascular disease, things like rheumatoid arthritis. The question then becomes, does intervention help?
And this is where I am the happy bearer of the greatest good news. And it's logic that when you clean the teeth and you take out the teeth that are so severely infected that they cannot be salvaged, then you take away the bacteria, the tartar on the teeth I haven't mentioned, but that basically the calculus on the teeth simply consists of calcified dental plaque. So when all that is taken out, then the contribution to the cumulative burden of inflammation decreases. And this can be measured. And many studies have now measured the effect on glycated hemoglobin by periodontal therapy. And the really good news is that you don't need a specialist in gum disease, a periodontist, to do this. You can have your dental hygienist or your dentist clean the teeth in what's called deep cleaning, which is cleaning between the teeth and the gums and take out all the hard and soft deposits and then polish the root surface to be as smooth as possible, right? So not only does this decrease the inflammatory burden, but you can measure it as a decrease in glycated hemoglobin. The most recent out of 3 systematic reviews by the Cochrane collaboration, which is the globally most well-respected team who does very high-quality systematic reviews where you throw out a huge big net and look at all the studies that have the same purpose. And they have now concluded, based on 30 randomized trials, that periodontal treatment using subgingival, so that's under the gum line, right, instrumentation, improves glycemic control in people with both periodontitis and diabetes. And what I have never seen in such a systematic review is the following, and I quote, "Further trials evaluating periodontal treatment versus no treatment or usual care are unlikely to change the overall conclusion reached this review." So the absolute reduction was found in HbA1c to be 0.43 percentage points after 3 to 4 months, 0.30% after 6 months, and 0.50 percentage points after 12 months, which results are both statistically and clinically significant. So this being periodontal treatment, represents a novel tool in the armament that diabetes care providers have at their disposal. It's just a question of thinking about it.
It sure is. Now, Wenche, this is fascinating to myself and I think our listeners, in that when someone is 0.5% above goal, an A1C of, say, 7.5 when you're trying to get them below 7, the first thing we think about, of course, is re-emphasis on lifestyle modification, diet, exercise, and then very quickly we move to adding an additional medicine. Now, traditionally, let's just say if someone was on metformin alone, often the next medicine might be a DPP-4 or an SGLT2 or TZD, and those medicines in general would yield an additional about 0.5 to 0.7% decrease in A1C. And I don't think we routinely think about revisiting oral hygiene and having someone see their dentist and emphasizing the importance of twice daily brushing as a way of decreasing A1C that is in the same approximate range as what we sometimes get when adding an additional medicine. So that's really impressive and I think very important information. So Wenche, clearly periodontal disease is critical. It is critical for people's health. It's critical for their well-being, their nutritional needs, and for systemic health. On our next podcast, the second in this series, we're going to cover in detail the things that can be done both in primary care and with dental care to prevent periodontal disease and to treat periodontal disease. We'll also talk during that podcast about the cost effectiveness of doing so. At this point, though, at a high level, when should we as clinicians think about recommending to patients to see their dentist?
All the time. The American Diabetes Association does mention, almost like a little aside advice, in their annual diabetes care series in January, that you see a dentist together with the not together, but as well as the podiatrist and other examinations when you're first diagnosed with diabetes. And then is a question between the dental care provider and the patient, how often any checkups should be happening, depending on what defined is the first time around. It may not be sufficient enough, the 6 monthly intervals. And I know it's very costly, but I hope we can discuss that later.
We sure will. So we're about out of time. Wenche, any last thoughts you want to leave our listeners with?
Yeah, I want to thank everybody for especially Neil, for the interest. As you can deduct, this is mostly a question of thinking about oral health in the everyday management. And I hope that listening to this session can have created some awareness of the role and importance of oral health. And then my mission is accomplished. This is my baby, my main interest. I'm so excited to share with you these things.
Wenche, you are so articulate and your passion comes through. And when someone is passionate about their message, everyone around them learns. I know we all have. Dr. Wenche Borgnakke, thank you so much for joining us.
Absolutely. My great pleasure.
And to our listeners, thank you for joining us in this first of a two-part series on an incredibly important topic that we don't think about often enough, that is oral health. These two special editions of Diabetes Core Update focused on oral health are sponsored by Haleon, the makers of Periodontics. Let me again share a message from our sponsor. Patients with type 2 diabetes are more likely to have gum disease, cavities, and other oral health problems. Periodontics is a daily use toothpaste that is clinically proven with twice daily brushing to reverse and prevent gingivitis, which is an early form of gum disease. Visit HaleonHealthPartner.com to learn more about the Periodontics portfolio of oral health products and how they can support your patients' gum health. We at ADA are so appreciative of Haleon sponsoring this important topic. It is a critically important topic. I think we've all learned a lot. And when you come back for our second podcast this series, we will learn some practical things that we can help do for our patients in order to help our patients achieve optimal oral health, and by achieving optimal oral health, also help them with better blood sugar control and diabetes health. We look forward to you joining us for the second part of this series for the American Diabetes Association. I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.